We are going to get started. I wanted to welcome everyone to the webinar. For those of you who don't know me, my name is Dr. Lauren Levine. I've been hosting and moderating these webinars for about 10 years or so. We, as usual, have hundreds of people that are registered. As always, I hope that everyone's staying healthy and safe out there. I commend you for being here this evening, continuing your dental education. I'm only going to speak for a couple of minutes. I want to make sure that Dr. Flucke can speak for as long as he needs. We also want to leave time at the end for questions. Most of you have been on these webinars, so you kind of know the format. On your screen, you have a GoToWebinar control panel where you can type in your questions. We can't do verbal questions when we have 500 plus people on, but we will try to get to as many questions at the end as we can, time permitting. If we don't get to your question, I apologize. I see the questions as they're coming in, so a lot of times I'll consolidate some questions or do a two-part or whatever just to make sure that John can get a chance to try to answer as many as possible. In the next few days, you're going to receive a few things. First off, this webinar, like all the webinars that I do, is recorded. So if for some reason you can't make it till the end or you get distracted, don't worry. You'll be sent a link, usually within a couple of days. So keep an eye out for that. During the webinar, Dr. Flucke is going to be showing some of the systems and products that he uses, some which are exclusive to Golden Dent. I want to thank Golden Dent for their sponsorship of these webinars. I've been working with Kurt for many, many years. They're the ones that bring in these amazing speakers. They're the ones that help to develop the content, and they also handle the CE. I get more questions about CE than any other thing that I do. So here's the basic process. You stay on for the webinar, you log out when you're done, you will be sent a CE form. With this many people on, that can usually take about a week or so. If you log on and then take off after 6 minutes, you will not be sent a CE form. That's not the way it works. You have to be logged in as well. We've had some people over the last few months that just called in to the phone number, which is the same for everybody, so we have no way of tracking that. If you're not seeing Dr. Flucke's screen right now, then you're not logged in. And you need to at least click that link so that you can see the screen so that you'll be registered. What we do at the end, I send the list to Kurt. He will go through it, and for people that were here for the bulk of the webinar, I think it's like 75, 80% or whatever, they'll be sent the CE. With that out of the way, I am thrilled to welcome Dr. John Flucke. I have known John for, I don't know, like 20 years. I mean, it's a long time. Something like those lines, John. In the IT world, dental IT world, there's not a lot of us out there that are fairly prominent and well known. Myself, John, Paul Feuerstein, Marty Jablow, and like I said, John is definitely one of the pioneers here. He is in private practice in Lee Summit, Missouri. He practices 4 days a week doing direct patient care. He's also the technology editor for Dental Products Report, which is where I write my monthly column. He's chief dental editor, where he writes, edits, and does video demos of products featured in his technology evangelist columns. John has one of the most popular dental blogs on the internet. Most of you, I'm sure, have heard of it, Ramblings of Dentistry's Technology Evangelist. It has daily updates on technology in healthcare and technology in general. The site has over 2 million unique page views, which is amazing. He lectures extensively on all aspects of clinical dentistry as well as technology in dentistry. He's been featured at every major dental meeting in the U.S. and international occasions as well. Dr. Flucke uses technology in every aspect of his practice and personal life. He pushes himself to constantly be on the leading edge. Like me, he loves testing and breaking the latest gear he can get his hands on. He lives by the motto, you can't have too many toys, and I completely agree with that. He consults with manufacturers, helping with development of techniques and technologies and products, which allows him to see things from the duct tape and zip tie stage all the way through to the completed item. Dr. Flucke's passion is technology that improves patient outcomes. He's always working to create or to help create products and techniques that allow patients a better quality of life. He's also the past president of the Greater Kansas City Dental Society, as well as serving as the Missouri State Peer Review Chairman. So, John, I am absolutely thrilled to have you here and looking forward to the presentation.
Thanks, Lauren. It's nice to be here. Yeah, you and I have known each other a long time. I remember that. I think it was it was either right before we met or shortly after we met that I learned that you were the digital dentist, and I remember thinking like, oh gosh, that's a great moniker. I wish I'd thought of that first, and I didn't. So I salute you. For those of you that are here tonight, um, yeah, Lauren and I go way back, and he is a true pioneer. I'm proud to call him my friend. He's the first dentist I ever knew that became a Microsoft certified engineer. Um, he has a great technology company that helps offices stay on the leading edge. So if you need any kind of services like that, he's too humble to tell you that he does that, but I'm not too humble to tell you how great he is. So thank you guys for having me tonight. Um, I am John Flucke. As Lauren said, I'm Chief Dental Editor and Technology Editor at Dental Products Report. And what I want to talk to you about tonight is something that is pretty phenomenal, I think, when it comes to general dentistry and the whole concept of doing clear aligner therapy, because clear aligner therapy has really come on in the last few years, and I think a lot of us are doing that. So let's kind of get started on this, and let's talk about what I'm doing and how I'm using things in the world of using clear aligners. And I just lost everything. Give me just 1 second, folks. Sorry about that. There we go. So IPR, interproximal reduction. Um, the factors that we're talking about here, orthodontic treatment utilizing clear aligner therapy, we frequently refer to that as IPR, interproximal reduction. It allows the doctor to create adequate space to achieve the desired results. The thing is, like any healthcare procedure, though, we need to consider the actual process of what we're doing. I often have humorously said that you could train a monkey to do a lot of the things I do, and Lauren might even say that the monkey might do it better, which might in some cases be true. But the difference between the monkey and the doctor is that as the doctor, we know why we're doing what we're doing. And then plus, as the doctor, we also have a responsibility to our patients to give them the best possible outcome. So today, I'd like to talk to you about some issues dealing with IPR. Interproximal reduction is one of the things that we do a lot of when we're doing clear aligner therapy. And you don't do a lot of this if you're using wires, simply because wires allow you to do some things that you can't do with plastic. And part of that is simply that the aligners, they lack anchorage to, we can't put uh, bands or brackets on molars that are so well anchored and then use those anchor points to move the teeth. We've got to use what we've got. And it's hard to move molars with aligners, but if we've got the space, we can make things look really, really pretty. And the problem with expanding the arch with orthodontics is that it works sometimes, but sometimes you've only got so much you can expand, and you can't always just solve that with expansion. And the thing about IPR is a really great way to create space. And when I say great, you'll notice here that predictable is in red here, and that's because of some of the factors I'm going to talk to you tonight, where that if you need space, you can create space. I'm going to take a drink of water, so I'm going to go quiet here for just a second. Sorry about that. I've got a water bottle here, just so you know, so I am not slugging out of a bottle of vodka if you hear it glugging. But whenever I go quiet, I may be taking a drink. So what we need, if you do clear aligner therapy at all, what you'll notice is when you get the information back from your provider, if you need IPR, they will give you a map, which looks like the arch, and they will generally indicate to you, in these areas, this is what you need. And it varies. You may see here you need 1/10 of a millimeter. Here you need 2/10. Maybe you need 3/10 over here. So you you've got these numbers and you need to accomplish that. But how do you accomplish that and get those areas that you want? So we know, if I talked about the monkey and the why. So we know the why is to create adequate space so we can properly align the teeth. Yet the way we create that space, in my opinion, is also a really big why. When I was a kid, they created space by routinely doing serial bicuspid extractions. And gosh, I'm getting old. I was born in the 60s, which makes me feel ancient now, especially in dentistry, where it seems like everybody's younger than me. But let's face it, if you extract all four of the premolars, you can create a lot of space, but we don't do that anymore. And that's because we figured out a better way to gain space. And we also figured out that serial bicuspid extraction brought a whole new set of problems and complications into the equation. And for those of you that are a little bit younger, there used to be something we used called headgear. And headgear attached, it was an appliance that attached to the maxillary molars, and you actually had an elastic headband. People would sleep in headgear. And what it would do was it drove the maxillary molars distally, and between serial bicuspid extraction and driving the molars towards the back of the mouth, they could create space. One of the things we found out now is as they were moving the teeth backwards and creating space in the mouth, they were also narrowing the airway. And a lot of those people that went through wearing headgear, myself included as a kid, we're now suffering from obstructive sleep apnea. And part of the reason is that we have really straight teeth, but we've got an airway the diameter of a drinking straw. So that's why we got away from serial extractions. So now that we've figured out a better way, I feel that we're obligated to study that better way, which is interproximal reduction, and figure out the least invasive way to perform that task. And at the end of the day, let's face it, we all work for the patient. And I think that's a really important point to bring up. Today, it isn't simply a matter of creating space. It's a matter of creating space in a way that I feel preserves the enamel while also leaving the enamel in a polished state that allows the patient to keep it clean and plaque free. Creating space is more than slicing through your interproximal spaces with a coarse flame-shaped diamond, or God forbid, a diamond disc. And I am going to talk a little bit about the risks of using discs in this in a couple of slides. But why should we pay attention or more attention when we talk about IPR? Well, creating space can be accomplished, in a lot of ways. And I mentioned the serial bicuspid extractions as that got us a lot of space. But it also was removing teeth, which, as dentists, we're all about conserving enamel and conserving tooth structure. And then suddenly somebody thought, and I know they did it with the best of intentions, but somebody thought, we can improve someone's quality of life by removing four of their teeth. And nowadays we know that that really isn't true. So what we really need when we're doing this is a way to predictably gain some space, and that we get the results we expect cosmetically, but we also allow the teeth to maintain their shape and maintain their finish, their polish, so we can keep them for the rest of our lives. I don't think it does a patient any good if we create space and we give them really nice straight teeth just so they can develop decay or periodontal problems on down the road, and they end up either the teeth, the anatomical part of the teeth being destroyed, or the support being destroyed in the long run. To many of us, the concept of IPR is kind of new. And once again, I'll go back to when I was trained. I know that when I was in school, and our training on orthodontic instruction was really, really basic. I think when I graduated, I was maybe either the first or the second class that was even given a course in orthodontics. And that was in the days, obviously, when we didn't have clear aligners, and that's why I probably didn't get a lot of training on interproximal reduction. And the other reason that they didn't talk about is that we didn't have products like DentaSonic that we're going to cover tonight. I like to think about performing IPR in a similar manner to doing composites. When I'm done with a composite, what I want is I want the finish to be as close to natural tooth structure as possible. And that means the margins are smooth, the margins are polished, the restoration is polished. I don't want plaque traps. I don't want any easy way for plaque or bacteria to accumulate. We want our restorations to be smooth, really polished, and just replace what the decay process took away and restore the teeth to their natural ability. So when we're done with IPR, it really should be the same way. We aren't just creating space. We're creating space, and after we create the space, we're then smoothing and polishing the tooth surface so that the plaque and bacteria can accumulate and create these breakdowns of the enamel and or the support system when we're all through with this. So let's face it, when you look at this bite wing, IPR can be difficult to perform. I know that it used to be pretty tough for me. I'm fortunate in that I found the DentaSonic system, but before then, I often dreaded having to perform IPR. When I would submit a case to my clear aligner partner, I would submit the case, and then, in a day or so, I would get the treatment plan back, and I would get an email that said, hey, you can log in and look at the treatment plan. And I would be like, oh, please, please, please don't give me a lot of IPR. Or if you give me some, I'm really hoping for none, but if you give me some, please let it be minimal and let it be, just the incisors so I can really get to it. Because trying to gain space by doing IPR in the posterior with the instruments that I had at the time was pretty difficult. So I want everybody here tonight to know that I'm not an orthodontist. I've never played one on TV, but I do really like improving smiles. And because of that, I really, really enjoy clear aligner therapy. It's one of my favorite treatments. But sometimes the prospect of IPR could take something out of something I enjoy doing and make it a bit of a chore for me, which isn't exactly the fun part of dentistry. At the end of the day, you want to enjoy what you do, and that's one of the reasons that I was really thrilled when I came across DentaSonic. That company took the aspect of IPR and it made it much more manageable from a doctor's perspective. It gave me peace of mind knowing that when the case was finished, the patient not only got a really great aesthetic result, they also got smooth enamel, didn't have scratches or gouges that would accumulate plaque and pathogens. What we're seeing here in this bite wing that I've got up here is obviously interproximal reduction gone wrong. This isn't my case, so I'm not exactly sure how we got to this point, but through experience and age, I think we can deduce that it was either done with some type of a coarse diamond with a point, maybe a pointed diamond or flame shaped, or maybe it was done with a diamond disc. And IPR can be really tough to do without the right equipment. It's especially difficult to get good results in the posterior where visualization can be tough. I'd be willing to bet that what happened here was what I call a perfect storm case. And what I mean by that is probably some limited opening combined with a frightened patient who was very nervous and couldn't hold still, probably some poor oral health care that resulted in some bleeding that obscured the field. And all of those things added up to create a situation that, went a little bit off the rails here. And let's face it, lots of our patients have limited opening. Lots of our patients are frightened. Lots of our patients have tissue that bleeds easily. These are the kind of things that we all see every day. And whenever we run into them, which is fairly often, at least in my experience, we think to ourselves, isn't there a better way to do this when you're doing IPR in those situations? And the answer to that is yes, finally, there is a better way. And it's called DentaSonic. So, in a situation like you're seeing here, as I said, probably done with either a pointed diamond, or I'm more inclined to think it was probably a diamond disc. Um, but I'm sure it was a very difficult thing to accomplish. And one of the problems with working in the posterior is you just don't have as great a visualization. And especially if you throw in things like limited opening, gingival bleeding, a patient that's scared and moving around, all of those things contribute to these kind of outcomes. And this is obviously one that no one would be proud of, but there's ways we can work and we can avoid these kind of situations if we can. So let's take a look. And what I want to do for the first few slides here is kind of show some things that didn't work out right. And then we're going to talk about, as I'm showing these, we're going to talk about the things that didn't go great, and then how we can improve on those, and what DentaSonic does in that regard to help you with that. So let's take a look at some things that that probably happen multiple days, or I'm sorry, multiple times a day across anybody's office. There's an old expression that my grandfather used to say that I love, and he used to say, "Son, when you're up to your backside in alligators, it's hard to remember that your original intention was to drain the swamp." And of course, that's just a funny way of saying sometimes what we think is a really great solution makes us more problems than we anticipated. And that can really apply to dentistry. I can tell you that from personal experience. So when we look at the following cases, just remember that all the doctor was trying to do was just gain a little space. All they wanted to do was just get some space to move the teeth to get the aesthetic result. So you can understand, you look at this case, you can understand what happened in this one. Somebody did some IPR in an attempt to gain some space. And obviously this is with wires, this isn't with clear aligners. So this is a tough one to fix in a minimally invasive aspect. You first need to obviously finish this case. You need to get the teeth straight and get them all lined up, but then you'll have to do something to get these proper contours back. And achieving those proper contours in the aesthetic zone can sometimes be a challenge, especially if you want to do it in a minimally invasive way. So part of this is that the human eye is drawn to things that don't line up with what we perceive in nature. I was a psych major in undergrad, and it's kind of incredible to me what people see and what they may not notice. But they'll look at a smile like this and say, "Gosh, there's something about that smile that's not quite right. I can't quite tell what it is." One of the things is the gingival contours are off, obviously, but the other thing is that those mesial surfaces on those centrals are pretty much straight up and down, and their eyes and their eyes will pick up on it, and their brain won't look at that probably and say, "Oh, the mesial contours of those centrals are off." But their eyes, their natural perceptions will look at that and they'll say something just isn't right about that, and they'll pick up on that aspect of it. And that makes fixing these situations even more critical and stressful for the treating doctor, because things like this, the main places that we're using IPR to gain space is in the aesthetic zone. And so you want to make sure that when you're doing this, you maintain the aesthetics that you started with. So we've got a similar situation here. Natural curvature of the centrals is gone, and the eye goes right to it. Now, this is probably either before the treatment is started, or maybe it's in mid-treatment. But these situations also create a treatment problem because the computer modeling for the aligners will be designed to straighten the teeth. But because in cases of aggressive IPR, you may end up with a diastema at the end of treatment, you then are faced with a choice. Do I fix that with some bonding here, or do I need to go back and do a refinement to try and close that better with the aligners? And either way, it's something that, that you really don't want to have to do if you can avoid it. Something else I want to make sure you consider as you look at all these cases that I'm showing is that every clear aligner company that I'm aware of sends a treatment simulation to the patient. And part of that, or a lot of that, is so the patient can see, well, this is what you look like today, or this is what you look like before you start. And this is what we anticipate the result being when we finish. And they will send that to the patient. The reason I bring this up is that the patient will have a record of what their teeth look like before, and some of them, there's the risk of them coming to you and saying, why do my front teeth look more straight in the middle now as far as the curvature? What happened? Because they used to be curved. And that can be a difficult thing to answer. I bring this up because with the proper way of gaining that space, you wouldn't have to answer that question because you'll get the space, but you can also keep the proper aesthetic contours. And that's one of the real benefits of a reciprocating system like DentaSonic. Plain and simple, a reciprocating handpiece is less aggressive and it gives you more control when you're doing cases like this. So this is one, whenever I see a photo or a video of a disc being used in the mouth, I either think that person must have just incredibly amazing skill, or it makes me nervous. Because these instruments might have had a place at some time. I've never used them, and I don't I don't like them because I think they're really hard to control. Um, they're fairly aggressive, and they're easy for them, at least in my hands. They're easy to get away from. I've used, a slow speed and a diamond disc before outside the mouth on doing denture adjustments and some other things, and I always feel like there's just that risk of that disc biting and then it kind of walking, and as I call it, and going someplace I don't want it to go. And when that happens in the mouth, you do have the risk of engaging the soft tissue. And whether it's the lip or the tongue or even the interdental papilla, um, discs are instruments that are just hard to control. And so they can get away from you and they can cause injuries in the blink of an eye. So um, using one of these, I like to tell people, is a little bit like endo and the broken endo file. A broken endo file doesn't really seem like a big deal until it happens. And then when it happens, we're like, oh man, I wish I wouldn't have done that, or I wish I would have used, some other instrumentation. But at the point it happens, you've already had a bad outcome. So if you catch the lip, there's a strong possibility of a cosmetic injury, and none of us want that to happen. But no matter the type of injury, there's no need to worry about it if you just don't take a disc in the mouth. So also, as you can see in this picture, they're not incredibly flexible. And because of that, it also means that it's really hard to use a disc and really maintain the proper contours and the curves that nature put in there in the first place. I tell my patients all the time, I'm good, but nothing is as good as what God installed at the factory. Factory equipment is best. So, there's lots of ways to create space, but sometimes creating the space causes other problems, and it's the alligators in the swamp thing all over again. So this is an example, I'm pretty sure was probably done with a disc. You can see by the weird contour of the distal lingual aspect of the second premolar. I'm guessing that the doctor was probably using a mirror to protect the tongue and made the approach from the lingual, but a little bit at the wrong angle, which could have been patient movement, could have been the patient tried to swallow and push the mirror into the disc or whatever. Also, if you look closely at the next interproximal space between those two premolars, you can definitely see the mesial aspect of that second premolar has been changed in addition to that distal. That second premolar looks kind of boxy now, and that's because both of those interproximal surfaces have had the disc used on them. So in this particular case, I don't think there's anything here that's catastrophic. The line angles you can round out with some type of finishing burrs, like a microfine finishing diamond or something. But the thing that I want you to take away from this is that if you'd used the right instrumentation, you might not have these kind of situations. And if these situations are things that you find occurring when you're doing interproximal reduction, then I've got a solution for you coming up here. So um, this is a bite wing of that case. And I want you to take a close look at that area marked with the red circle here. Notice the contact point here. It's way lower than it anatomically should be. The contact point is pretty much at the bottom of what I refer to in these situations as the IPR slice. So instead of the contact being about a third of the height of the margin, or third of the height below the marginal ridge, it's at the lowest point in that height of contour. And the reason for that is simply because there's no height of contour here anymore due to the instrumentation. And the previous area that had a natural curvature was removed with the use of an inflexible instrument, and that doesn't allow the operator to keep those proper contours. So the other thing I want you to take note of is the shape of the embrasure area. This contact now is kind of V-shaped, which is open at the top. And as the physics of mastication are applied and you start to chew in this area, that shape is going to allow for pretty constant food packing into that area. Now, it may not reach the gingiva, so you may not have a situation where the forces are driving the food into the soft tissue and creating, at first a foreign body reaction, which is acute. But then if things are constantly getting engaged there, it's hard for the patient to get in there and clean it out. You may end up with a periodontal problem there with like loss of some support. None of us want to have something like that happen. The only way to fix this is to add material to that distal surface of the premolar, or tip the premolar distally to try and put the contact back up higher. Either of those fixes are going to be not the easiest thing to do if they can be accomplished. So probably the easiest way to correct this would be to put a small DO composite in that area, but it's just easier to not have to have the problem in the first place. Also, if you take a look once again at the mesial contact of that second premolar, that contact is flat like it was in the photo. And this is going to be much more difficult to keep clean and maintain than the way nature intended, because the contact is much longer and thicker. And so it's just less of an ideal shape. So again, it'd be great if we had a way to accomplish the IPR and we didn't have to be concerned about, creating other problems that we then had to deal with on down the road. So we've got a similar case here, loss of contour as well as some flat contacts. One of the things that I noticed with this case is these teeth have got a little bit of recession, so they're a bit longer than natural, but I think the loss of contour also changes the eye's perception, and it makes them look even longer than they really are. So we're smack in the middle of the aesthetic zone here. We're dealing with centrals. And the one thing working the doctor's favor here is that when something like this happens on the lower, it's less noticeable than something on the uppers. As we all know, lower anteriors show much more when we speak than when we smile. So a situation like this is much less stress inducing for the doctor than those maxillary cases. However, if this causes a food trap, it's going to be right in the front. And that's not a great thing from an aesthetic standpoint when a patient is, out to dinner with friends or whatever. They've got to constantly be rinsing or trying to use something to, get the food out of those areas because they're impaction points. So once again, flat contacts in the aesthetic zone, centrals are tipped a tad distally. We're not done here with the case. When they're moved into alignment, this will probably decrease a lot or disappear, but they still look flat. And natural teeth have a curvature for a reason. And removing those curves almost always creates some type of problem. As a lot of us that have done cosmetic stuff will know, even just the facial contours, if you change the facial contours of teeth with even like really small no prep veneers, sometimes changing those contours creates food traps. Just amazing how, a tenth of a millimeter difference in curvatures can make such a big difference to the human body, but it can. So The point I'd like to make on this one is that it's not so noticeable in a social situation, mean on the lower, but in situations like this, when the patient looks at themselves in the mirror, they're looking dead on. And so they see that in a way that most patients or most other friends of patients, acquaintances of patients wouldn't see because they're not looking at them dead on. But it is something that probably patients notice more than, than anybody else, simply because they go home, they look in the mirror, they stand very close to the mirror. Some of our more aesthetically conscious patients will spend a long time looking at themselves, just a few inches from the mirror, and they're going to notice things. So let's get down to it. I've shown you some things that either you don't want to do or you don't want to have happen. But now let's talk about the right way to do IPR. And just to clarify, I want everybody to know I'm not a superstar. I'm not some golden-handed, gifted clinician that, has people lined up at my door to do aesthetic cases. And I don't have people flying into Kansas City where I live to, have me treat them. I'm just a general dentist in the trenches. I'm just like all of you that are listening. And I honestly think that's probably one of the reasons the DentaSonic people wanted me to talk to you, is because I'm a GP and I see the same type of cases and I see the same situations that everybody that is at this webinar tonight deals with. When I started out doing ortho, as I said earlier, I didn't get any ortho training, or my ortho training in school was minimal. And that's just the way it was back then. That's not really a complaint. It's just a fact. But I started doing orthodontics when clear aligner therapy came along. And I didn't want to do wires. That seemed pretty complicated to me, and I just didn't want to get involved in that. So I stayed away from it, had several good friends that were orthodontists. I just let them deal with it. But when the clear aligners came along, and I saw that so many patients were coming in with ortho relapse cases where the molars are in great position, but almost everybody, I threw my retainers away, or I lost my retainers in college, or I lost my retainers in my 20s, or I just quit wearing them in my 20s, and now I'm in my 30s, 40s, 50s, and my teeth are starting to, they don't say rebound, but I'll say it because that's the term we use. My teeth are starting to rebound and, go back to the way they were. And all you want to do is just straighten them up. You don't have to drive the molars anywhere. And I was like, this is exactly the kind of stuff that I want to do. So I started doing this. And of course, one of the big things with clear aligners is interproximal reduction. I did the best I could with the instrumentation that I had available at the time. And for me, that meant a lot of microfine finishing diamonds that were super skinny. I love the microfine finishers that they're almost gray. They almost don't look like they have a grit on them. I do a lot of my composite initial finishing with them before I go into the polishing phases. And so those were what I used. I would either use a flame shape or a needle shape, and the grit on those is so fine that the burrs really look gray. They almost appear smooth or have like just a very little slight twinkle if you get them in your headlight. But my point here is that there was not much grit because I wanted to try and preserve as much enamel as possible. And I also used finishing strips or strips with a handle. So here's kind of a funny story about finishing strips with me. I started out with metal diamond finishing strips. They were serrated on one side. They had a coarse, they were divided into half. The front half was a coarse diamond, the back half was a very fine diamond. And they were used for a lot of things, interproximal finishing of composites and all kinds of things. And so we had those. And then they came along with the strips that have little C-shaped handles on them. And so we had two types of finishing strips. And because we had two kinds, if I'd ask my assistant, give me a finishing strip, she would always be, which one? And so one day I said, we got to figure out a better terminology here. So my assistant said, well, the handles, those little ones that you can hold between your thumb and forefinger, the handles are kind of C-shaped. Why don't we call them seesaws? She thought that was kind of funny. And then it was funny because I was like, yeah, seesaws. And then, of course, after a moment, we both looked at each other and we were like, no. No, never say saw. So we thought that's scary. So we came up with the idea. We call them seahorses or a seahorse. So I know that the name sounds kind of goofy, and it is. It's really benign. But even though the word horse has nothing to do with finishing, to this day, which is like a decade later, we still call them seahorses. So go figure. But now let's talk about something better than strips or seahorses. So what's so special about DentaSonic? In a nutshell, this system allows doctors to really predictably and really easily create the needed space for IPR while also allowing you to maintain the contours and the finishing. So not only do you finish with a tooth shape, but you also finish with a tooth polish, which is really nice. Developed a quick point of reference that helps me adopt when I'm looking at new technologies. Over the years, I really have done a lot in tech over the years. As Lauren said, he and I have both been in this since the 90s, or for me, the very early 90s. And so I came up with 3 questions that I use when I'm looking at something. I'm like, do I want to bring this into my practice? Do I want to introduce it to my patients? So question number 1 is, does it give me at least the same result or a better result than I was getting before? I said before, whether you are the chairman of the board of a dental supply company or whether you're a dentist in the trenches like myself, we all work for the patient. So I need to make sure that quality wise, if I bring something new on board, I'm not taking a step back. I want to put my head on the pillow at night and know that I gave the patient my very best effort. If you give your best every day, you'll be successful, hands down. For you young dentists, don't concentrate on money, concentrate on your patients and concentrate on results, and you will have more success you know what to do with. Question 2 is, does it save time or effort? And that works for both the patient and the doctor. No patient wants more dental appointments, more checks, or they don't want those appointments to take any longer. I've been at this for a long time now. I have never had a patient say, can you slow down? Can this take longer? Can you drill for like another half hour? Or I've never done an endo and said, we get done and could you put the rubber dam back on for like 15 minutes? Because I was enjoying that. People want to get in and out. And I get that. We're all busy. I'm busy too. There's also the advantage of the time savings for the doctor. The less time you spend doing dentistry, either the more patients you can see, if that's what you want to do, or the less stress you put on yourself. And this is an interesting thing that I always want young doctors to know, because I was at one time bulletproof and I was never going to die and I was never going to be, the person that I am now. But I learned a statistic about 15 years ago that just stopped me cold, which is well over 60% of dentists that become totally disabled from work-related injuries do so because of neck and back issues. So because of that, I became a big fan of efficiency to make my procedures last less time. And it took me out of what I call, I'm making air quotes, the clinical posture. Because the less time I spend in that posture that we have to be in to treat patients, the less strain it puts on my body. You can practice longer, you can fund your retirement longer, and you can help the patients that trust us. Also, if the doctor isn't physically fit and can't practice, that affects a lot of people. It affects the doctor, it affects the team, because in a busy dental office, everybody earns a living because the doctor is there. So if the doctor suddenly ends up having to retire because they can't practice anymore because they're injured, everybody in that office has got to find another job. And I wouldn't wish that on anybody else. The third question I ask is, does it cash flow? So it's, do I get as good a result or better? Does it save time or effort? Does it cash flow? I don't like to talk about money much because, as I said a couple of minutes ago, I've always felt that if you give your patients your absolute best and look out for them as people, you'll do fine. But there's also the simple fact that you can be the best operator on the planet, have the best hands, the best skills. But if you cannot stay in business, those hands and those skills will not help anybody. So you've got to look at how does this work as far as costs as well. So take a look at this. This is what DentaSonic allows you to do. It gets you through the contact point really quickly and really easily with a little thin saw. You can then, once you've got that initial little space created, you go in there with this less aggressive, not coarse diamond grit, and you then smooth the tooth, keeping the right contours, and you don't end up with these flat spots between the teeth. They have these really great, and I'll show you a picture or pictures of the kit and the refills of the situation before we're done tonight. But these strips are in really close tolerance thickness classes. So when you pick up a 0.1, you know it's a 0.1, and that helps you do your job better because you're not picking up a burr and like, oh, I need 0.3 millimeters. Oh, that looks kind of like 0.3 millimeters. You know that you're finishing to 0.3 millimeters or whatever it is that you need. And then they have a little polishing strip called the polish strip, and you go in with that at the end, and that takes away all the scratches and all the roughness, and it then gives you an interproximal surface that your patient can maintain, and it gives them health, for their lifetime. So how do we do this? We do it with a reciprocating handpiece, and that means that these strips are going back and forth, and they're not spinning like a traditional turbine or electric gear handpiece. So it works a little like a little saw. It goes back and forth and back and forth and back and forth, and it takes those abrasive strips and it moves them, in that motion. The strips are engineered to these thicknesses, and they're flexible, and that's a really key point. When they're flexible, it allows you to apply the pressure where it needs to be applied, and as you go through that contact, you can then move the strip more towards the tooth to help maintain those contacts. They're very precisely engineered, so you know exactly what you're getting, and then that poly strip just lets you polish it back to like a glass-like smoothness. So when I used manual strips, it was really kind of a chore to use them correctly. I had to be really careful of the lips and the tongue and the commissure of the mouth. Even just the edge of a strip can create a tiny slice in the lip, and while that isn't something that could cause you a big cosmetic problem in the future, those suckers do hurt like crazy for 2 or 3 days. And I always hated telling patients, well, I'm sorry, but I got your lip a little bit with the edge of this thing. It's kind of like a paper cut, and I'm sorry about that. It's not going to be a big deal, and it's going to stop bleeding in a couple of minutes. Sometimes we have to apply a little pressure, but I always feel bad about it. I'm a Midwestern Catholic guy, and I feel guilty about everything. So this is just one more thing to throw on the fire. So I also had the little seahorse strips, and those were sometimes a better option, but they were still hard to use. I didn't cut very many people when I was using those. But they were kind of hard to use. They were kind of hard to get the right reduction done. And what I've found is a handpiece is just so much easier, and it's so much more simple. As dentists, we're so used to that feeling of the handpiece, that instrument in our hands just gives us a tremendous benefit. It's easy to control, and that makes it good for the doctor and the patient. So when we're looking at the teeth, how much can we really take away? And these were some studies that were done at the University of Heidelberg, which is why their logo is here. And generally speaking, we have a limit of 0.5 millimeters of IPR. And what that means is that allows us to take about 0.25 millimeters from either side. And that keeps you in that zone if you still have enough enamel that you have, enamel for a lifetime there. You've still got, the adequate thickness that you need. And that's one of the really critical things I think about DentaSonic is that because the strips are engineered to these really tight tolerances, you know how much you're taking away. And they make the strips in both a two-sided and a one-sided version. So if you've got a tooth maybe that's a little bulbous and maybe you can it can spare a little more space, you can use one of those one-sided strips. Or if you've got adequate space on one side but not the other, they're very easy, and it just helps you to be super conservative, yet you get the results you need, and it keeps those contours that nature put in there at the factory, which is really, I think, really important. The whole idea is you're not supposed to take away more than 0.3 millimeters of proximal substance. So that means that you take away 0.25 on each side and you're fine. So this is just kind of look like how much can we take away on the tooth. And I'm not going to dwell on this slide very long. Charts are great. If you really want to know about this for later, grab your phone real quick and take a picture. The main takeaway I want you to take from this is that removing enamel and creating space should not be what I call a best guess scenario. It should be as precise and accurate as possible. So that accuracy isn't even remotely possible with a handpiece and any type of burr. I don't care how skilled you are. Using a diamond burr does not allow for you to have the amount of control necessary to perform really precise IPR. The process of IPR should be done using a precision system with precision instrumentation, and you can't eyeball a process like this. And I will gladly admit, before I found DentaSonic, I was not nearly this precise. Now, when I approach these cases, I do it with the peace of mind that comes from knowing that I've got more control and more precision than I used to have. And the thing to remember here is that when you're dealing with these type of thicknesses or distances, we need to be accurate. So think about this. We like our crown margins in pros. The digital scanners that are available today, the crowns that you get back from your lab or that you're doing in-house with a mill, is we want those margins accurate to about 50 microns. That's the dental standard. 50 microns is 0.05 millimeters. And we all know that's a tiny distance. I mean, even though that's a huge distance to us in dentistry, we know in the real world, I mean, I tell people a lot of times in my practice, I'll tell patients, I live in a world where a millimeter is a gargantuan distance. And we all know, all of you listening, you know it is. So when you're talking about doing IPR and the partner company that's giving you your clear aligners, they give you your map and they say, in this area, we need 0.5 millimeters. That's 0.25 millimeters per side. And that is 250 microns, which is only 5 times the width of a crown margin. So we're talking about a quarter of a millimeter. Would you trust your unguided hands to remove that amount of tooth structure? I ask that because I've been practicing for a number of years now, and I like to think that at this point in my career, my hands are pretty good. Now, that's not me trying to make myself look good. It's just that Malcolm Gladwell, who's a great author, wrote a book that some of you may have read, but if you haven't, you should. Gladwell wrote a book called Outliers. And in that book, he puts forth the idea that to be really good at something, it takes about 10,000 hours of experience. So I've never sat down and figured out how many hours I've spent doing dentistry, but I'm sure that it's probably a lot more than 10,000. So hopefully, following the rule at 10,000, I've got decent skills at this point. But if somebody came up to me and said, Flucke, sit down and go between these two teeth and only remove 250 microns of tooth structure, let's say on the distal aspect of the first premolar, I'm not sure I could say, yeah, piece of cake. I'd probably say, well, I'll do my best, but it's really hard and I can't guarantee you that I can do it. So what I really love about DentaSonic is it gives me much more control and much more comfort in doing things like that. So reminds me of placing implants. Before we had CBCT and we used surgical guides. Implants were placed by people that had really good hands and lots of hours of implant placement. And now that we have surgical guides, we can get ideal results by using a tool that helps us be more accurate. It helps our hands perform. And that's how I feel about IPR, is DentaSonic just makes me more efficient and more accurate. It makes my job easier and it gives me a better result. So the enamel thickness of the teeth, it varies due to the tooth in question. However, the thinnest enamel layer on any of the teeth is the maxillary incisors, or I'm sorry, the mandibular incisors. And for those teeth, the average enamel thickness for the mandibular incisors is about 0.68 millimeters. So what that means is even in situations where you're doing 0.5 IPR, removing 0.25 millimeters from each side still leaves you 0.43 millimeters of enamel, which is plenty. So, but if you can accomplish this by carefully doing IPR with a precision system, trying to do this with a thin, coarse diamond burr and removing only 0.25 millimeters, it's not something that I think I could do. And I'll gladly admit that even if I sat down and you challenged me to it and I did it and I got it once, that's probably the most that you would ever see me hit. Because it's just hard to do with just your eyes and your hands. And as the need for IPR decreases, if you need like less and less structure taken away, you've got to be more and more precise. So if you need 0.3 millimeters of space, that means you're going to be removing 0.15 millimeters on each side. And you just got to be more accurate with that. And I'll gladly tell you that I am not that good. I'd like to tell you that I am, but I'm not. There's no way I'm that good. So how much enamel can we, get and reduce on a tooth? If you look at the maxilla in this one, this is a European numbering system. So the way the FDI numerical system is that the centrals are 1, the laterals are 2, and the canines are 3, and then you go off of the quadrant. So like 1-1 is the right central, 2-1 is the left central, which is kind of a cool way of looking at things. But in those contact points, you can basically get about 3 millimeters of space. That's how much you can gain. If you can go, further back and go from first molar to first molar, which is 6 to 6. In fact, I think it's really great. Some of my friends that are not American dentists, when they refer somebody for third molar extractions or wisdom tooth extractions, they'll talk about extracting the 8ths because the third molars are the 8th tooth in the arch, which I think is kind of cool. So working 6 to 6, which gives you 11 contact points from first molar, you can gain about 6.6 millimeters, which is a decent amount of space. On the mandible, it's pretty similar, but a little less. So from canine to canine, you can get 2.6 millimeters. And then if you go from first molar to first molar, you can get 6.2 millimeters of space, which, is a decent amount of space to gain when all you're doing is trying to rearrange like maybe canine to canine and not worrying as much about the premolars. And especially on these rebound cases or relapse cases, the molars are locked into position, so those are even easier to deal with. So it's also handy when you're dealing with the Bolton discrepancy. For those of you that don't know, I'm not going to make a big, long oration about the Bolton discrepancy, although it's very, very interesting. The Bolton analysis, just real quickly, is a tooth analysis. It determines the discrepancy between your maxillary and your mandibular teeth. So the formula is basically the percentage obtained by adding the sum of the widths of the 12 mandibular teeth divided by the sum of the widths of the 12 maxillary teeth. And it ought to be about 91.3. So you can use this to analyze just the interiors, or you can use it to analyze the entire mouth, depending. It's a great way to analyze space. One of the other things that you can see here is these centrals are a little wider. They're outside the golden proportion a bit. So you've got, some contouring that you can do here. And once again, taking a flexible strip and passing it through those areas and keeping them that way is going to be really, really nice. Gives you a good result. Now, this is some electron microscopy that I wanted to show you. The above portion of this is before the poly strip was used, and then that lower portion is after that poly strip is used. And once again, this is from Germany, and that's why we've got the logo here, and that's why the black bar down there is not in English. But what I want you to really look at on this is look how smooth that finish is, and that's from that poly strip. So you don't have to leave the teeth scuffed when you're done. You can really bring them back and make them beautiful. So this is just some more scanning electron micrographs, SEMs, and you can see the untreated and the treated in that image on the left. And then we're just zooming in more and more on these 500 times on the left, 2,000 times in the middle and on the right. So this is some great stuff to use. This is the kind of thing that you want to end up with when you're done with IPR, and getting a result like this. Trust me, you just can't do this if you're winging this with a needle diamond or a flame-shaped diamond. You just can't do this, and you really can't do this even with really nice seahorse strips. It's really hard to do. But doing this with a handpiece that goes back and forth, and it goes right where you want it to go, and you can control the pressure, you can get some amazing results with DentaSonic. So I know I showed you this slide earlier. I put in here a second time just to reemphasize how really safe and easy this DentaSonic system is. It's quick, it's gentle. Each strip is a precise thickness, so you know exactly what you're doing. And then, as you just saw in those SEMs, once you've achieved the right amount of IPR, you can polish the enamel to the point that it just almost looks like glass. It's really incredible. So let's take a look now and see, how do we use this? So here's the handpiece. We've locked it on, and then the little saw goes in there, and this opens the space. And then you'll notice we're just going to go through these. We're going to go up in width as we do this. So going through each time, that strip is getting a little bit wider until we're all done with that. And then this is that poly strip. And you'll notice all of these are very flexible. They bend when you're doing that, and that gives you that really nice, smooth, glossy. You really can't tell that anything was done. And look at the contours here. The contours are really, really natural. And that's what we're trying to get. We don't want those straight up and down shovel-shaped incisors. So they make this in a couple of versions. The one you just saw is a contra angle. It goes on an E-speed motor, which will work on any electric system. It will also work on an electric endo motor if you'd like it to. But this is the cordless version, which is really nice because you obviously don't have to have this hooked up to an air hose. And it is really cool. One of the super cool things I think about this is that not only can you use it for your IPR, but you can also use it for polishing composites. And then that bottom point, you can use it for endo. So this, in addition to being a cordless IPR motor, it's also a cordless polishing motor, and it's a cordless endo motor. So it does them all. which is really, really cool. So, this is kind of a 3 temperatures, 1 detergent kind of situation. We've got one motor that does 3 different things. I think that's amazing. I mentioned a little while ago, I was going to show you some kits in here. This is the starter kit 2. And as you can see, it's got the E-Speed contra angle on there. And then it comes with everything that you're going to need, all the strips with all the thicknesses. And then one thing I do want to point out to you, on the right-hand side of that box, on the bottom portion, you'll notice a little kind of goldish thing there in the middle that looks like a key. That is a thickness gauge, and it looks like a little key ring. You take those out, and those little keys are each the same thickness as the different strips. So if you want to make absolutely rock solid sure that you have the amount of IPR that you need to do the case, you can take those keys out and use those as thickness gauges. Very, very handy. But everything you need is here. You can also get this little basic set, which comes with the contra angle and then one of each of the strips. And that's a better picture, I think, of the little gold key thickness gauges that I just talked about. Very handy. And then if you want to, you can just buy the hand pieces. Only real difference on this is that third one, the DS Twist 40. It has a little bit higher speed. It's a 40,000 RPM as opposed to the others are 25. But all of these work really, really well. And if you don't have an E-Speed motor, you can buy that motor on here or from these folks as well as the contra angle. And then when you're done, or when you've got this and you've used it for a while, and when the strips are done, then how do you replenish your supply of strips? Well, they sell the resupply kits, so you can buy them in a 12-pack. You can buy them in an assorted 5-pack as well, or you can also, if you just want one certain thickness, you can order those as well in 12 or 5 packs. So you've always got these available. You always got these handy. One other thing that they've come out with, which I think is really nice, this is kind of a recent change, is along the arch there, the colored arch on these, they also have the thickness. So you don't have to just memorize the color and know this color means this, or like the yellow strip is a diastrip. You can look at it and actually see, oh, this is the 0.10, this is the 0.20, because it says so right on the little arch, which once again is handy. They're color coded, but in case you forget what the colors are, there's a number there to remind you. So I'm wrapping up, everybody. It took me about an hour, I think, to do this. I want to thank you guys for being here. I always try and end with this slide because I want you to know that dentistry is stressful. Life is stressful. Technology can do wonderful things for us, but it can also be stressful. The most important thing is if you take dentistry home with you and you think about it and you worry about it, as I think probably all of us do, I know I sure have over the years, just keep yourself grounded. Never think about how much money you made. Just think about the important things in life, because life changes fast. And as Ferris Bueller said, if you don't look around every once in a while, you're going to miss something. And that one was taken a couple of months ago. They're now 26 training dolphins in San Diego, 23 working for NASA, and 16, and she's got more artistic ability in her little finger than I've got in my whole body. So thank you guys for watching. Thanks for spending the time with me. If you would like to jump to the website or see more about DentaSonic, there's a little QR code there that you can use your phone to do that with. And I am very, very grateful that you all have spent some time with me today. I'm going to stop sharing my screen and I'm going to turn it back over to Lauren and Kurt.
Thank you, John. I'm pleased to say that fortunately your kids got your wife's good looks. So,
Yes, they did. Thank God for that, my friend.
so I mean, before I turn over to Kurt, just a reminder. I mentioned this at the beginning, so some people may have showed up a little bit late. The webinar was recorded, so typically it takes a couple of days for that recording to go out. You'll get that as long as you register for the webinar, which you're here. For the continuing education credits, that usually takes about a week or so. I send the list to Kurt. He goes through it. As long as you're here for the bulk of the webinar, obviously if you only showed up for 5 minutes, you're not getting CE. But if you're here for like 75, 80%, I'm not sure what the exact number is that they have to use for AGD PACE, but if you were here, if you started at the beginning and you're still here, you're going to get the CE. There's nothing you need to do. There's no quiz. There's no registration or test or anything like that. One of the things I mentioned at the beginning is that we don't have these webinars without partners, and I have been very fortunate to work with Golden Dent over the last number of years in order to be able to put on these presentations, to have these amazing speakers like Dr. Flucke, to be able to get you guys CE, et cetera, et cetera. So normally, and including this webinar, we are fortunate to have Kurt Lawler from Golden Dent. They are always really good about making some type of special offering or some deals. So I'm going to turn it over to Kurt right now, and then we've got some time left at the end for Q&A. Kurt, take it away.
Yeah, Lauren, I appreciate it. My name is Kurt Lawler. I'm with Golden Dent, based here in Detroit. We're a third-generational dental family that focuses on providing simple, predictable, and we look for unconventional dental products such as DentaSonic. So this one's uses a handpiece or a motor, and that's one thing that we liked about this system here. So I'm just going to go over a couple slides here. I'm going to try to stay on topic. I don't have too much more to add. The kits were shown, the product was described through the webinar this evening. But for anybody that might be new, one of our goals for next year is to provide new topics for webinars. We've done a ton of webinars on extractions and grafting, media dentures, endo, implants. So we're trying to add a couple new topics for the year and continue to look for more webinar invites on new topics such as IPR like we did this evening. So just a little background real quick on our company. We started with extractions and grafting. Physics forceps was the first product that we made. And then we have all of the allograft sutures, bone grafting instruments that go along with extractions and grafting. We then got into the endo area. We have the woodpecker products, including all their endomotors, obturation systems, endophiles, apex locators. One thing that I did take a look at earlier this week, unfortunately, the DentaSonic contraangular handpiece or head does not, unfortunately, fit on the woodpecker motors. It looks very similar, but I have not been able to get that to work quite yet. I was hoping that would work because they do have the reciprocating motion, but so far that doesn't work if anybody has that question. Implant, so this is our implant motor. Absolutely, the DentaSonic handpiece does fit on our woodpecker implant air model. I also tried it on our electric motor, which is our MT2 and MT3 from woodpecker. And then these are just some of the other implant products that we got into after the endo. Just recently, we've had good success with scalers and air polishers. So this has been a great alternative to some other popular brand names on the market. We have a combination air polisher and a scaler unit and some different ultrasonic scalers and tips. And then lastly, related to the topic that was discussed this evening, this is our restorative line. So we do have our own sectional matrix system, curing light, and then now you can find on our website here under restorative IPR and restorative strips, we have gone ahead and just as of this week added the DentaSonic basic kits onto the website. These are the normal retail pricing that's shown here. I will provide a promo code here in a moment. But if you're looking for any of the DentaSonic products, I did put the initial kits on there and some of the starter kit packages. I don't have every single strip on there individually yet, but that's something we'll be doing here in the future. Lastly, before I turn over the Q&A, I just wanted to mention we always have a lot of great courses. We've done these for years with Dr. R. Nazarian. These are hands-on live patient programs. We do extraction programs. We do extractions and grafting programs. We do extractions and grafting in preparation for immediate denture. And then we have our Endo 4 GP program that we do here also in our office here in Detroit. So that's under the amplifydental.com website address. I just wanted to mention we do education for anybody that's new on the webinar this evening that hasn't joined in the past. Lastly, we always provide a promotional code. So we know you invested an hour of your time with us this evening. We show new products usually on the webinars and techniques, and we give a promotional code to encourage you to further evaluate those products in your office and at a promotional or discounted pricing. The code this evening is going to be IPR 15, and that will discount the DentaSonic products or any other products on our website. If you're already using our graft material or anything, it's a good chance to take advantage of a coupon code, I guess. So it's IPR 15, and the website's golden-dent, so there is a hyphen there. And then our phone number's on the screen. We're always available on chat. Feel free to give us a call anytime in the office related to any of the products that were shown this evening, and we'll do our best to get you the answers. So I'll turn it back to Lauren for any questions for Dr. Flucke that were asked this evening on the webinar. Thank you, everybody.
Thank you, Kurt. John, you ready to hit some few questions here?
Sorry about that. I muted myself for a second. Yeah, I'm ready.
Okay, so the strips, are they single use? And if not, how many uses will you typically get before you need to change one?
Okay, they're not single use. The people DentaSonic would probably love it if they were. Now, seriously, I probably get somewhere between like 5 to 10 uses out of them. And what I tell people on that, Lauren, is it's kind of like a burr. How do you know when they don't work anymore? I tell people it's kind of like using the force. You know, you can just tell, like when is a scalpel blade dull? You can just tell. And you know, when is a burr dull? Same thing. So you can tell when these things lose their efficiency. But I find that I get between, I don't know, like 5, maybe if I don't really lean on them, 10 cases per piece.
Okay. So speaking of force, do you ever is there some way that someone would be able to avoid, say, removing too much enamel because they had a little too much pressure on the mesial-distal when they were using the strip?
Yeah, it's nice because you can vary this. It's a great thing about it being on a motor, and this is one of the really nice things about the cordless one is that you can actually control the RPMs, which is nice. Now you can obviously on the air driven, you can use your foot with that. But yeah, you can definitely control what you're doing. You can control by the amount of, the amount of back and forth, the oscillation of it. But you can also control with just the amount of pressure. And it doesn't take very long to figure that out. We showed you that video with the Dentiform. And I'm always a big one. Before I do anything, I call it going live when I actually start using something with patients. And before I always go live, I will always bench test it, whatever it is. And, so you sit down, you take a Dentiform, you do a couple of quick run throughs with it. And it's not something that, takes a lot of feel to get good at. You do this a couple of times and you're ready to rock.
Okay. Some of the things I think you answered during the presentation, but we'll get to it again. How much enamel can you reduce on the tooth in order to be on the safe side?
You can reduce 0.3 millimeters, stay within the safe zone, and that's one of the reasons why I like I said before, I'm not an orthodontist and I don't claim to have all the orthodontic answers, but in my career of using clear aligners, the most that I've ever seen a company ask for as far as like, we need you to create some space here, the most I've ever seen was 0.5. And of course that's accomplished with 0.25 on each side. And so you're well within that 0.3 aspect of things.
Okay. How do you, like, when you're actually removing enamel? How do you know how much you're removing? Is that based on the coating of the strips?
Yeah, and the thickness of the strips. The strips, the amazing thing to me is I'm such a big nerd, I actually have a digital micrometer. So when I got the strips, the first thing I did was like, oh, 0.3, huh? Okay. So I get the little digital, micrometer out and think, wow, 0.3, spot on. So, and I tried all the strips and they were all like that. So the nice thing about it is that what some people do with IPR is they think, oh, I've got to get this to, 0.3 on this tooth. And what they do, or they need that space, I'm sorry, they need 0.3 in a space. And so what they do is they pick up a strip or one of the little, like I call them seahorses, and they just look at the one and go, I want the one that's 0.3. And then they try and, go through that. And in reality, what you really need to do is start with like a really thin one. And then once the thin one passes through easily, you graduate until you get to the thickness you want. And that's the nice thing about this DentaSonic system is that you just always start out with the very first one, which is really skinny and it's really easy to pass through. And then because those strips are flexible, you kind of just push, mesial and distal a little bit. And once get the free play in it, then you just take the handpiece out, put the next level thickness in, and it's very precise. So when you put the two-sided 0.3 in there, when that thing passes through really easily, you've taken 0.15 off of each side, and then you stop. It's kind of like endo. If you use rotary endo, that after a bit you can just tell, okay, the file is just floating, it's not even hardly engaging anything anymore, it's
Right.
time to move to the next size up. It's the same kind of feel.
Yeah, makes sense. What about you showed the case that you showed were mostly straight teeth. What about like on crowded, rotated teeth? Are there modifications you need to make as far as like the angle that the IPR should go in?
Yeah, the important thing to remember is you want to try and keep this thing aligned with the long axis of the teeth that you're performing the IPR on. So on a case with a lot of crowding, what I will do is that, and this is why I love some of the one-sided strips. They're so nice because it's like if I need to remove some material from, the mesial of a lower central, but then I've got a lot of crowding in that area, and those mesial areas on those two teeth aren't lined up right. I can take a flexible one-sided strip and go in and work against the long axis of the tooth on one tooth, and then I can flip back around and use another one-sided strip to go to the other side and keep that
Hmm.
aligned properly, so you're not just like willy-nilly sawing through and creating a straight line through there, which is unfortunately what you have to do with like a disc or a burr. And because these strips are so flexible, you can do what I just discussed easily without having to worry about, oh, I've just, this tooth looks good, but the tooth next to it is now, all mutilated. I've got to try and worry about how do I fix that.
Sure. What compared to when you were doing manual IPR, what type of time savings are you seeing that is taking you half the amount of time, a third of the amount of time? Like, what type of time savings are you seeing on average versus when you used to do it manually?
I'd say at least half. Um, and of course, in case that this, but a lot of the people listening may not. I talk a lot, so I'm not always working. I'm swapping
Mm.
stories or talking with my patients, but the actual process is probably, I would say, it's probably twice as fast, maybe faster than the manual way. I mean, it's very much, if you think about, I would compare the manual with like a slow speed, and the DentaSonic system with like a high speed. You wouldn't cut a crown prep with a slow speed. I mean, you could, but you'd be there all day. And that's kind of the way I feel that the manual strips are. It's just you can do it, but it's just a lot of work, and plus it's hard on your hands.
Right. What about, I mean, those things look kind of sharp. Any concerns about soft tissue damage when using these?
if the patient moves. I have never, gosh, I shouldn't even say this because this means tomorrow I'll do it, but I'll knock on
Of
my desk here and say
course.
that I haven't, I've cut people with strips, and that's not a slight on strips. I mean, that's just kind of the nature of the beast. I've cut people with strips, never cut people with the DentaSonic. Um,
Well,
I think it's harder because they're short, and because of the way they work, because of that oscillation, you don't have to use a lot of pressure. They'll kind of walk themselves and guide themselves down into the interproximal areas. So you don't have to push really hard. So it's not like all of a sudden, you've broken through the contact and suddenly, it goes down and slices into the tissue. Um, I can tell you that I've occasionally had people go, ow, but I don't remember the last time I made somebody bleed.
okay. Speaking of that, do you hear anything from your patients as far as their experience with using the DentaSonic versus a manual IPR or
You know,
other IPR kits?
yeah, the dentist, it's really kind of funny because there were times when I was using uh, just the strips, and this is, the long strips and then what I call the seahorses. I used to use both of those. And there were times when I would have like teeth that were really not in alignment, and I'm trying to get the doggone strip through there. And I don't have little hands, unfortunately. And I would almost treat those longer strips like floss. I'd try and like wrap the ends around my finger a little bit, and then I would try and, like get it to go through the contact. And unfortunately, sometimes it was kind of tough, and the patients would, their head would be moving while I'm trying to do that. And I actually had a guy say one time, "You starting a lawnmower there, doc?" Um, so with the DentaSonic, because it moves so fast and it's just so efficient that you don't get that bind thing. You just go through, and it's much easier.
Okay. Is there risk of doing too much reduction if you use the same strip too long or past a certain reduction amount if it no longer is reducing the enamel?
Yeah, if you stay, it's like anything in dentistry. If you hold something uh against something for too long, you're going to remove more than you want to. And that applies to burrs. um, if you're doing a crown prep, you take a diamond burr and you just put it one spot, you step on the pedal and you just push, and you don't walk that burr around or paint with it, as they used to tell me to do in school. Use it like a paintbrush, Fluky. um, yeah, you can remove more than you want to. The nice thing about the DentaSonic system that I think is great is that, once again, using that endo analogy, when you take those, the first thin strips through, you take it through, and it may be you'll feel a little resistance, not a lot, but a little. And then when it breaks through and you feel like, okay, yep, it's moving freely, then I just go to the next one. Um, and so I don't linger too long. I mean, once I've got what I call play, where I can feel that I'm not having to work it on either side to get through the space, then I go to the next one. And um, I don't feel like I'm taking too much away at all.
Okay. I think we have one last question here.
Okay.
So, what if you're doing an IPR where one of the teeth is a natural tooth, but the other one is, say, like a porcelain crown? Is there any modifications you need to make on those circumstances?
I would personally, what I would do is, if I can keep the right contours and the right aesthetics, I'd prefer to remove more off of the crown than I would the tooth, because I just I'm like an enamel lover. So if I can accomplish something without taking enamel away, I'm all about it. But once again, if you have, let's say that somebody's got a crown on tooth number 8, and tooth number 9 is a natural tooth. If I well, let's use 8, it's a crown, and I ruin the contours, and suddenly the aesthetics are all messed up because one of the teeth is, straight up and down, and one of them's got nice, pretty contours, and I really haven't helped myself too much. So all things being equal, I'd prefer to take more off of the porcelain, um, but it's about the aesthetics. So if I'm ruining the
Right.
aesthetics, I'm just going to split the difference.
Okay. Makes sense. Well, we're right at the bottom of the hour, so I'm going to give you a chance to give us some parting comments here, and then we'll call it a night.
Okay. It's a really simple, it's a really easy system to use. I am honestly kind of amazed at how easy it is to use. So if you're doing clear aligners and you want to do more or you want to do them better, I think it's a great system for that. But the other thing, my other parting thing would be, it's not about how many zeros are in the bank account. That is the least of your worries. I'm not sure which English queen it was. I think it was Queen Victoria I, but supposedly her dying words were, "All my possessions for just more time." And, that's time with loved ones. It's time with, your family and doing the things you love. Dentistry is a means to an end, but don't let it be everything to you. Don't take it home. Don't feel guilty when things don't go right, because it happens to all of us. But also, if all you care about is money, be careful, because money feels exactly the same way. And those are my parting words.
Works for me. When we, as I mentioned, I do a lot of webinars with Golden Dent and other companies, and occasionally Kurt will reach out to me to say, hey, we're bringing in a new speaker. Do you know anything about this person, and what do you think? When he mentioned to me that John Flucke was going to speak, it took me about a millisecond to say, yes, I've known John a long time. I know all about his integrity and his experience. He's, like I said, there's very few of us that focus on dental technology, but John is at the top of that heap. So, John, I really appreciate you joining us and sharing your experience. We'd love to get you back sometime. We'll talk to Kurt about that. As a final reminder, for those of you who didn't hear it the first or second time I mentioned it, the webinar is recorded. That recording will go out in usually a couple of days. The CE forms take about a week or so. Golden Dent sends those out. I send them a list of everyone when you logged in, when you logged out, and then they shoot off the CE for you. There's nothing you need to do on your part. There's no test or quiz or registration or anything like that. They just look about how much time you spent on the webinar, and then they'll send out the CE. If you don't have it by, say, next Wednesday, I would say normally let me know, but I'm going to be on Mount Kilimanjaro trying to get to the top in a week. So I won't. Yeah, thank you. So I won't be able to necessarily respond quickly. It won't be until the 19th when I'm back. I certainly do recommend that if you want to take advantage of these specials, the IPR 15 code is 15% off. You can call them up on the number that you see there. Just go into their chat at golden-dent.com, and they can talk to you and answer any questions that you have as well. So please, everyone, stay safe and healthy. This was our last webinar of the year, but starting in January, we're going to be right back at it. So all of you who were here this evening are on my list for invitations for future webinars. Please stay safe and healthy, and we look forward to seeing you all on our future webinars. Good night, everyone.
Good night. Thanks, Lauren. I appreciate it. It's been a pleasure to be here.
Anytime, John. Anything for you.
Cool. Thanks.